This rhythm is fast, wide, and fatal. And in clinical practice, I'm sure most of us must have come across such kind of ECGs frequently. However, if we look at the rhythm strip properly, we'll notice that there are certain absurd wave patterns or even strikingly normal ones amidst this chaos. So let's decode what these are. Hello everyone, welcome to the Rhythm Files episode 6. Let's take a look at this case. So this unusually normal wave amidst the ventricular tachycardia rhythm strip is known as the capture beat. This happens when the SA node takes its role as the pacemaker instead of the ventricular ectopic focus. The second one, which appears absurd and neither resembles VT or a normal wave, this is known as the fusion beat. This happens when both the physiological and the ectopic pacemaker fire simultaneously. So let's take a quick look at the key characteristics of this ECG of ventricular tachycardia. So there's Josephson's notch, which occurs when there is a notch on the downstroke of the QRS complex. So this happens when there is defective activation or delayed activation of the ventricles. Second is the Brugada sign. Then there is rabbit ear appearance, which indicates the origin of the ectopic focus from the outflow tract. Then there is AV dissociation, capture beats, fusion beats. It's obviously a wide QRS complex tachycardia with a rate between 100 to 250 beats per minute. And usually we'll see extreme right axis deviation in this case. So this is a quick review for the acute and long-term management of ventricular tachycardia. If it's an unstable VT, we go for synchronized cardioversion. If it's a pulseless VT, we go for defibrillation. In a stable monomorphic patient, we prefer amiodarone or procainamide or lidocaine infusions. In the long-term management, beta blockers are titrated to the target dose. Guideline-directed medical therapy for heart failure or LV dysfunction is to be done, and optimization of electrolytes is of utmost importance. Now, those who are survivors of cardiac arrest due to VT or VF, or those with sustained VT with structural heart disease and ejection fraction of less than 35% despite GDMT, and those with prior MI and ejection fraction of less than 30% are class 1 indications of implantable cardioverter defibrillator. Okay, so the cardioversion algorithm aims to identify the real candidates for cardioversion. So quick preparation, setting up of equipment, consideration of sedation has to be done, and synchronized shock has to be delivered. The energy selection guide has been mentioned here for different types of arrhythmias as well. Thank you. Please like and follow.